Thank you. So these are the various formulas that we can get from the Warren Hill site. So here we have the older generation versions formulas, then the ray tracing, then we have the his own Hill RBF formula. But now we know that there are two ways of looking at biometry. One is to use the ultrasound biometry and the older formulas. The Royal College still advises us based on the axial length of the eye. So if you're going to do your biometry based on axial length, 80% of your patients will be within 0.5 diopter. But if you choose to use the OCT-based biometer and the more recent formulas, 92% of your post-ops will be within 0.5 diopter spherical error, and another 98% will be within 0.75 diopter. These are the easily attainable targets in all parts of the world. So why is the axial length-based formula not enough? This seminal article by Jack Holliday showed us that there are many types of eyes. For the common eye, where you have a normal range of axial length and cornea, any formula will work. But we do have unusual eyes, like a large eye with butyl mass with axial myopia, or we have eyes with microcornea and axial myopia, where the normal relationship between the front and the back of the eye is lost. And we need more measurements, and not only the K and the axial length, to find out the correct IOL in these eyes. Server Nosby in 2008 showed us that as far as biometry errors are concerned, 1/3 of the error is found from the position of the lens. This is the ELP error that we have. A third is in refraction lane length, and the skill of the refractionist contributes to a third of the error. And the last third is a result of both axial length measurement and K reading measurement. This was his finding in 2008. Wolfgang Hages, whom we lost last year, showed us that as of last year, the axial length measurements have reached a very high level of accuracy. And today we can find out the changes in the axial length with each beat of the heart. We can find out the changes in the axial length in the morning and in the evening. So axial length measurements are not going to, more accurate measurements are not going to help us. It is the corneal K reading, and that is the key as far as the future is concerned. So which is a perfect formula? Till recently, we had this confusion, which is a perfect formula? But a wonderful study 2 years ago showed us that the ideal formula for optical biometry users was the Barrett suite of formulas. And this study was the Mellis and co-author study. It's interesting to note that one of the co-authors is Jack Holliday himself. And the purpose was to find out the accuracy of the current generation formulas. So there were 13,301 cataract operations where an Alcon single piece lens was used. And the conclusion was very simple. Overall, Barrett's Universal 2 had the lowest prediction error for these two intraocular lenses. Now, it's interesting to note that all these calculations were done using the lens star and one particular type of intraocular lens. If you're using various kind of intraocular lenses, your prediction error will be different, and the spread of your post-op results will also be different, although the mean can be brought towards zero. So it's important to use a good quality lens, and one of the most repeatable instruments is a lens star. If you look at the current generation of formulae, both Hill RBF and the Barretts are all based on lens star measurements and the Alcon single piece platform. We really don't have formula which have been derived from the other instruments. So this is a graph from that particular article. It's very easy to find. Just see this black line here. This black line shows the common axial length. So for powers between 16 and plus 26, you will find that almost all formulas give very good results. This dotted line is a zero error. So if you take the zero line, you'll find that almost all formulas are good for this average normal common eyes. And if you take a spread of minus 0.25 and a plus 0.25, you will find that the Barrett's is totally within this particular zone. So based on this, he found that this was the best. The recent version of is always found in the APACRS website. There is no single Barrett's formula. It's actually a suite. It's a group of formula, And you have the Barrett's True K formula, which is applicable for myopic, hyperopic LASIK, for eyes where PRK has been done, where radial keratotomy has been done, and where keratoconus eyes are there. So this is where the Gulston ratio has been altered. For them, use the True K formula. Then when you want to do a lens exchange or a piggyback lens, you have to use the Barrett RX formula. Use the Barrett Toric calculator as your go-to for all your patients. And this is the basic spherical error calculation which underpins all the other formulae, the Barrett's Universal 2 formula. So you have a group of formulas, and this is the Barrett suite of formula. So this particular patient needed a lens exchange. Pre-op, he had a dislocated lens with a thick after cataract. You can use the lens exchange Barrett's RX formula, and then you can do the surgery, and you can find out the power for that. Barrett's True K should be used primarily for eyes that have undergone LASIK, PRK, and for keratoconus. This is the mandatory entry form for the Barrett's Universal formula. The optional data that you can enter is the lens thickness and the white to white. But even without these two, you will get a very good value for most of your eyes. White to white and lens thickness only matters when the lens thickness is very high, more than around 4.5. Below that, it will not matter. Barrett's formula, like Dr. Atik and previous speakers, including Dr. Arul mentioned, gives you the option of using the predicted posterior corneal astigmatism or the measured posterior corneal astigmatism. Use the predicted posterior corneal astigmatism for all virgin eyes. It also helps you to calculate the integrated K value. Integrated K value is slightly better than using the K from any one instrument. You have the option of using 3 different instruments. It can be a topographer, IOL master, Lenstar, Aladdin, manual K, auto K. Any one of this can be used. 2 of the entries have to be from a biometer, and the last one has to be from a topographer. If you enter any 2 values, you will get an average value. If you can enter 3 values, you will get a median value. So the median value of 3 data points from the same patient is used to calculate the integrated K. That integrated K forms the basis of the anterior corneal measurement, and then the PCA is applied to that. The predicted posterior cornea is applied to that, and then it is used in the Toric calculator. So these are the 3 different entries that you can make. The last one has to be a topography. The first 2 are biometry values. Then this is the Toric calculator where you want to use the actual measured True K value, and this is of use in LASIK eyes and in keratoconus, where the Gulston ratio is altered. The True K values can be obtained from the IOL Master 700 Pentacam, any SSOCT device, an OptoView, or from any Schlein plug device. Because the zone measured and the way each of these instruments calculate is slightly different from one another, it is useful for you to choose the option correctly. This is found free in the AP-ACRS site. Today you can find it out in the ASCRS site also, but this particular AP-ACRS site gets updated more frequently. Now, this is where we were 2 years ago. Then, right out of the blue, the same group of co-authors, Ronald Mellis and co-authors, came out with one more paper the next year, published in 2019 April. The new Kane formula was the most accurate of them all. So they went back to the same set of data, and they found that the excellent performance of the Kane, Olsen, and Barrett's formula in both short and long eyes is noteworthy given the historical difficulty in accurately predicting these groups. So you have one formula, the Kane formula, which is slightly better than the Barrett's formula. Most of us did not believe it till the second article came out in JCRS January 2020, where they went and assessed an independent group of data from one single surgeon in Bristol in the National Health Service. Overall, in each axial length subgroup, the Kane formula was more accurate than the Barrett's in this particular paper. Kane formula entry form is very simple. You just need axial length K1, K2, and ACD. You don't need the lens thickness, that's optional. Then you have a non-toric part, a toric part, and a keratoconus. So all in one. You don't have many different formula. Non-toric, toric keratoconus in one simple interface. It is optional to enter the lens thickness and the CCT. This doesn't seem to make much of a change. The Kane keratoconus formula had a statistically significantly lower MAE when compared to all the remaining formula. So, Kane keratoconus formula is more accurate than the Barrett's and any other available formula as of now. Now, Kane is not the only one. The EVO formula was first presented in ESCRS in Portugal. It was discovered by Tun Kuan Yeo of Singapore. And for this also, you need K1, K2 axial length, optical ACD. Optional is lens thickness and the central corneal thickness. This is interesting. These two are optional. This is the only formula, to my knowledge, which has been modeled on the Technis group of lenses and also MA60. It is not primarily derived from the Alcon group of lenses. And also, it is primarily derived from the Argos biometer and not from the rest. The Kane formula also has a IOL Master 700 Total K entry. The version 2 will accept a Total K from non-IOL Master 700 sources also. The EVO formula, the EVO formula also has a more advanced version, the EVO Toric formula, where you can do toric calculations. So this is Dr. Tun Kuan Yeo of Singapore, and he acknowledges the mentorship of Dr. Graham Barrett. He did his internship with him, then he came back to Singapore, started his private practice, and then he pursued his own dreams. So in summary, careful measurements on a virgin eye are very important. Use the Royal College advisory for ultrasound biometry. Consider Kane, EVO, and the Barrett's formula when you're using optical biometry. My dear friends, in summary, this is an evolving field. There is no end, and in the near future, we can look forward to more astonishing revelations and discoveries. Thank you very much.